You're listening to This Week in Cardiology from theheart.org on Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or, Alexa, what's my flash briefing? I hope you'll join us.
Hi, everyone. This is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for December 10th, 2021. This week, Afib, blood pressure rises during the pandemic, long COVID, cardiac arrest care, and a brief word on social media. First up, AF triggers. Now, what triggers an AF episode in an individual patient comes up often. If you can find a pattern to PAF, the solution is easy. Just avoid the trigger. The UCSF group has done and is doing great work on AF triggers, which is a topic that we see all the time in cardiology clinic. They recently presented and published in JAMA Cardiology the I-STOP Afib trial, first author Greg Marcus. This trial tested the hypothesis that N of 1 trials of self-selected AF triggers would improve quality of life in patients with Afib. An N of 1 trial is when a patient acts as their own control. This differs from regular trials in which we get mean outcomes from two populations, the active arm and the control arm. An N of 1 trial can demonstrate how a given individual react to particular interventions. I think the best example of N of 1 trials was the statin side effect trial called SAMSON, which I've covered before on this podcast. SAMSON is when patients took a statin or a placebo or no pills on alternating months. In I-STOP Afib, one group of patients, the active arm, received instructions electronically to expose or avoid self-selected triggers in random one-week blocks. Now, the menu of triggers that they could choose from came from previous studies which documented common AF triggers, say alcohol or caffeine or a big meal. The patient chose which trigger they wanted to test. Now, most chose caffeine or alcohol. Participants in this group were texted something like, okay, this is your week to expose yourself to the trigger, and then on other weeks, this is your week to avoid your trigger. The alternating weeks of avoidance exposure went on for 6 weeks, and then that was followed by a 4-week period of lifestyle change. In total, the trial blocks were 10 weeks. Now, the control arm just simply monitored their AFib over the same period. After the initial 10-week study period, all participants were given the option to end the study participation, or they could go on to test up to 4 additional triggers, each of these the same way, with those 6 weeks alternating N of 1 trials, followed by a 4-week lifestyle change period. Both groups received Cardia smartphone ECG recording devices, and Afib was assessed by either self-report or Cardia strips. The primary outcome, comparing N of 1 and control groups, was an Afib quality of life questionnaire done at 10 weeks. There was nearly 500 patients, age 58 on average. The main result was no significant difference in Afib quality of life amongst the two groups. However, in the 4-week post-intervention follow-up period, significantly fewer daily AF episodes were reported after the trigger testing compared with controls over the same time period, 40% less Afib. It's weird, though, isn't it, that those randomized to alternating weeks testing their triggers self-reported 40% fewer Afib episodes, but that did not lead to better quality of life. The trial authors also included a meta-analysis of all these individualized N of 1 trials and found only exposure to alcohol was associated with significantly increased risk of Afib events. The authors speculated on a tension between finding no difference in Afib quality of life in those who repeatedly tested their triggers and also the fact that there was less Afib. Now, maybe the Afib questionnaire is not ideal. Maybe the trial was underpowered. It's hard to say. I think the main contribution of this study was that alcohol again came out as the only reliable trigger, and while caffeine was the most commonly selected trigger that patients chose to test, it failed to exhibit any relationship with AFib. iStop AFib was a pragmatic trial. There was dropout and plenty of other limitations, which the authors described in a very lengthy limitations section in JAMA Cardiology. One of the main limits is that cardiomobile devices require active monitoring. You have to decide when to record your ECG. Newer devices that are coming, such as smartwatches and are always on, may increase the sensitivity and specificity of AF detection. But despite this trial's limits, I like it because it exposes the vast uncertainty in AFib pathophysiology and treatment. Now here, we have a highly selected group of patients who signed up for this study, a group you'd expect to be very sensitive to empowering stuff like supervised N-of-1 trials, who then have less AFib in the intervention arm, yet this does not translate to better quality of life. Now, you all know I've been skeptical of digital health. On the one hand, I love technology as much as anyone, but on the other hand, there are many, many, many causal factors on the road to good health besides surrogate markers such as your cardiac rhythm. You also have to consider the possibility here of reverse causality, meaning being connected and focused on triggers and AFib could possibly decrease one's perception of health. Maybe the control arm just got busy living and having more fun in life and weren't worried about the monitor. Perhaps a contrarian lesson here is that less monitoring could be better. In the end, of course, helping patients with AFib is humbling. There is much more than a rhythm monitoring and ablation. There are equal parts psychology and cheerleading and friendship. The Heart.org Medscape Cardiology has a very nice features piece discussing the AFib trigger study. Professor Jag Singh, a Harvard electrophysiologist, interviews PI Greg Marcus from the UCSF regarding both the trials from UCSF. It's a 17-minute interview. There's an edited transcript, and it's worth a look. They also discuss the UCSF study called CRAVE study, which featured real-time ECG monitoring after exposure to caffeine. This was presented at AHA, but not yet published. At least I couldn't find it. I will wait for the CRAVE paper, but the short story was, again, caffeine did not promote atrial ectopy or AFib, but it did increase PVCs and disrupt sleep. Next topic are blood pressure rises during the pandemic. A Cleveland Clinic group led by Luke Laughlin published a research letter in Circulation chronicling a rise in blood pressure observed during adults during the pandemic. This was a longitudinal study, which means over time, of employees and their partners and spouses from states who participated in a wellness program organized by Quest Diagnostics. The study included nearly 500,000 individuals with data from 2018 to 2021. Now, changes in blood pressure from 2018 to 2019 showed no significant difference, but in contrast, annual blood pressure increase was significantly higher in April to December 2020 than it was in 2019, and the p-value was off the charts low. The increases in blood pressure range from 1.1 to 2.5 millimeters of mercury, and all age groups were affected, but women and older adults had the largest blood pressure increases. The authors tell us in the discussion section that in population-level studies, small increases in systolic blood pressure of 2 millimeters of mercury are associated with significant increases in mortality from stroke and ischemic heart disease. They proposed the possibility of a forthcoming increase in major adverse cardiac events. And I highlight this observation because it comports with my observations in our clinic. The vast majority of patients I see have had worsening of their cardiometabolic risk factors. Rare is the patient who's gained fitness, lost weight, and drank less alcohol during the pandemic. Most of the arrhythmia patients we see have gained weight, now have higher blood pressure, and lost fitness. I did telehealth for 6 weeks in early 2020, and it was awful for my health. You're sitting around, you're snacking, you're exercising less, and just a mental stimulation, you miss the normal interactions and bustle of the hospital. I am no public health expert, of course, but reports like this, and of course our experience in clinic, which observes the worsening metabolic health of many people, I think illustrates one of the negative externalities of the COVID mitigation policies. The pandemic's health toll will extend far beyond the infectious disease realm. Next topic are direct-acting oral anticoagulation after VTE, venous thromboembolism. Both apixaban and rivaroxaban are used to treat VTE. They've never been compared head-to-head. A University of Pennsylvania retrospective new user cohort study published in the Annals of Internal Medicine attempts to sort out which drug works better. The data source is a U.S.-based commercial health insurance database. The primary endpoint of this study was recurrent VTE. Primary safety endpoint, of course, bleeding. After propensity score matching, apixaban versus rivaroxaban was associated with a lower rate for recurrent VTE, hazard ratio 0.77, so a 23% reduction. The bleeding rate was also 40% less on apixaban versus rivaroxaban. The problem I hope everyone already knows is that these were non-randomized groups. Propensity matching is a technique used to try to match baseline characteristics of two groups. But the only real way to do that is, of course, randomization. Always remember, friends, without randomization, the decision to use one therapy, apixaban or rivaroxaban, is made by a clinician seeing a patient. That clinician makes the decision for many reasons, some of which are on a spreadsheet, but others are not. Now, fortunately, there are ongoing RCTs enrolling now and comparing different therapies of VTE. Until then, I don't think we should use this sort of data to feel like apixaban should be preferred. In Afib, at least, I tend to feel that apixaban is the better anticoagulant, but I'm often reminded that rivaroxaban is once daily, and that is not nothing. Recall, my friends, the drubbing that the twice-daily ticagrelor took against once-daily prasugrel in the ISAR REACT 5 randomized controlled trial of PCI in ACS patients. Once-daily drugs have a serious adherence advantage. Okay, next topic, long COVID. In the journal JACC Heart Failure, a group of investigators published a report of 41 patients with post-acute sequelae of severe acute respiratory syndrome from SARS-CoV-2. These patients had persistent dyspnea on exertion and underwent cardiopulmonary exercise testing, or CPET. The syndrome is called PASC. Now, first, a word on cardiopulmonary exercise testing. This is different from the standard treadmill in which you just look at exercise tolerance, blood pressure, and stress ECG. In CPET, you get much more information on pulmonary function and oxygen delivery to the muscles. It's what's used to test endurance athletes. I was 18 men, 23 women, average age 45 years, normal left ventricular ejection fraction at 59. The peak VO2 was low at 20.3, which is 77% predicted. 58% of patients had peak VO2 of less than 80% of predicted. 15 of 17 patients with normal peak VO2 had ventilatory abnormalities, including high respiratory rates or dysfunctional breathing. Now, for the whole cohort, 88% of patients had ventilatory abnormalities with dysfunctional breathing, and nearly half the patients met criteria for myalgic encephalomyelitis chronic fatigue syndrome. So in sum, the majority of patients had both circulatory and ventilatory issues. The authors postulate that this could be due to cardiac, lung, and muscle injury from the acute infection. Now, while this is a very detailed report and it provides interesting observations, the problem I see in making any conclusions and translating this data to try and help patients are twofold. First, you don't know what one's cardiac and pulmonary function was before they had infection. A sub-average VO2 max means nothing if you don't know what the person could do pre-COVID. The second problem is you don't know if these findings are specific to SARS-CoV-2. For instance, in 2020, I had a viral pneumonia, non-COVID, but pneumonia that turned into a bacterial pneumonia, ended up with bilateral infiltrates, fever, and O2 sats in the 80s for a week. I wasn't right for at least 3 months. I would have flunked a CPET test, and when I tried to exercise months later, I had utterly disordered breathing. Thus, what we want to know is whether these abnormalities in cardiopulmonary exercise testing follow any kind of pulmonary infection. I suspect they do. Next topic today is cardiac arrest. I have to say the community who studies resuscitation science do it right. This week, JAMA published another RCT from a Danish group studying the treatment of patients who have out-of-hospital cardiac arrest. The question, does IV calcium improve outcomes? It's a plausible thing, right? Because calcium might help given its role in contractility. And two small trials done way back in the 1980s found no significant difference with calcium. However, both those trials had point estimates that favored calcium. And of course, you know that small trials that have numerically fewer events in the treatment arm, but not enough of a difference, could simply be underpowered and suffer from a false negative result. This is called a type 2 error. So the best way to settle the question is not with a retrospective review of charts comparing survival in patients who received calcium versus those who did not. The best way to answer the question is to randomize patients who have out-of-hospital cardiac arrest to calcium or not. And that's what this group did. First author was Mikkel Fink-Valentin. The primary endpoint was straightforward, return of spontaneous circulation, about 200 patients in each group. And the results were clear. Calcium did not work. 19% in the calcium group had return of spontaneous circulation compared with 27% in the saline group. The trial was then stopped for a potential harm. Now, this trial makes the podcast for two reasons. The small reason is that we now know not to give calcium for out-of-hospital cardiac arrest, but the main reason I mention it is as a shining example of how to answer important questions in medicine. You have to have the courage to test things with prospective, blinded, randomized trials. Now imagine if calcium was beneficial and all these years we've been omitting something helpful. The final topic today is a couple comments on social media. Medscape Medical News covered a new survey from Press Ganey on consumer trends in 2021. The first chapter of this survey was titled The Modern Patient Journey. The key finding of this survey was that 83% of respondents said they went online to read reviews of a physician after receiving a referral from another provider. I realize what I'm about to say seems like a banal thing to say on a podcast, but it relates to advice I have given in numerous lectures on social media, and it's one I learned from Dr. V, Dr. Brian Vardabedian. Well, Dr. V says, you can create your own story or it will be created for you. You have 100% control over what you say about yourself and near 0% of what others say about you online. His point, and I agree with it, is that it seems wise to have a web presence that you have created. A web page, a blog, a Twitter feed, a place where if a prospective patient Googles you, they will find out who you are. What do you believe? The problem with patient reviews are that the N is small, and most people who get good experiences are not motivated to write reviews. This is what they expect from the doctor. So a couple of bad reviews really stand out. Now, imagine if before someone gets to your reviews, they see your personal website, your blog, your Twitter feed. These are things that you control. Well, for those publishing a ton of stuff academically, you'll have an internet presence, but most of us don't publish that much. And I have to say, it doesn't take long to create a public presence, and then you get to define yourself. So that's it for this week in cardiology. As always, I'm grateful that you listened, and thank you. And my friends, remember, if you like this podcast, please take the time to give us a rating, write us a brief 1 or 2 sentence review. This helps others find us. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.